Hello and welcome to the channel and welcome to this video. In this video we're going to talk about dizziness, so let's just get on to it. There's no acronym for this, so it's not going to be your Socrates, but hopefully this what we're going to talk about is going to make a good sense to you, so you can have a good way to take a dizziness type history taking and have a good approach. So like any type of history station, now S normally stands for site, but because this is not necessarily exploring pain, in this case I change it up to call it like a situation. So situation. So what is going on? Why did the patient present with these symptoms? Okay. Now you can add also another thing. So what did they mean by dizziness? Okay, dizziness. Let's say explore. Okay, what do I mean with that? Is it like a spinning sensation? Spinning sensation? Or is it like a motion? Like a motion, a movement sensation? Is it movement? It's quite important to explore what the patient mean by dizziness. Okay, so obviously you want to go for O for onset. So when did it start? Did it start? Or it could be like a acute, or all of a sudden. Or should we just say sudden? Or gradual onset. It's quite important to know what is going on. So D for duration. So how long they last. Episodes last. It's quite important to know how long do they last, so you can have an idea where is, what is going on. F for frequency. How often are they getting these symptoms of dizziness? Okay, now let's go to the associated symptom. Now this is you can do it the way you want, but when it comes to associated symptoms, I like to explore a lot of symptoms just to have an idea what may be going on. So obviously I start with any nausea. I can say plus or minus vomiting. Obviously if there's vomiting, ask if there's any blood or anything like that. Any hearing loss. Okay, we will explore why that is an important question. You can ask a bit more question on any discharge, so any air discharge. Okay, then you can say any blocked ear sensation. Okay, so we're kind of like going from top to bottom. Any visual disturbances. That could be like blurred vision or double vision, any of those things. Okay, and don't forget to ask about like head trauma. Have they banged their head anyway, or had a recent fall? You just never know. And any recent illnesses. I would say mainly upper respiratory tract infection, so URTI, and now you can ask about fever and stuff like that. Then you can carry on with some systemic type questions if you're not too sure. After you've done that, you want to ask obviously what makes it worse or better. Okay, let's say worse or better. And one of the common questions I ask is it worse with head movement? Head movement. So that gives you a quick idea of how to take a quick history and for dizziness. Now let's go to the common causes that you may have dizziness. So one of the common causes for dizziness is obviously, this is a long word, benign paroxysmal positional vertigo. In short word, BPV. BPV. I'm not going to repeat that. Okay. The common feature is like a sudden onset. Okay. I would say last about plus minus 30 seconds, oftentimes less than that, and worse with head movement. Okay, so that's your first differential movement. Okay, the second differential you should be aware is maybe medication. Let's just say meds. Common medication that could cause that is obviously alcohol. If you drink too much, you're going to be dizzy. Some antibiotics, mainly metronidazole, that's the one I'm thinking about, and salicylate such as aspirin. Sometimes some patients will present with dizziness after taking an overdose of aspirin. Another common condition that you may see, especially in primary care, is Meniere disease. Oftentimes, patients that present with Meniere disease, they have a family history of Meniere disease, so that's a good indication. Obviously, the person will present with vertigo symptoms, which is dizziness. Do we have tinnitus, which is like a ringing sensation in their ears? Oftentimes we have also hearing loss, so that's why it's very important we were taking the history to ask about hearing loss. This can last a few minutes to hours. Okay, so it should last not a couple of days. Let's move this to the left a little bit. Another common cause of vertigo is viral labyrinthitis. So viral labyrinthitis. This is actually, oh my god, I can't even write. Titis. Sorry, my writing today is awful. This often happen after a upper respiratory infection. So I'll just say after upper respiratory tract infection. So it's very common to have this. The patient will have really severe dizziness. Oftentimes they can't even function. They're just on the bed all day. Plus hearing disturbances, issues, I would say, hearing issues. And they may also have tinnitus. You will notice that this is quite a common presentation with vertigo. Otalgia, which is ear pain, and then we have nausea, and fever. Okay, so it's important to note this as a differential. And the last one you guys should be aware of is the vestibular neuritis. So let's look for a space. Vestibular neuritis. Okay, again, this often happen after a recent illness, mainly upper respiratory tract infection. Patient will present with nausea and vomiting. Nausea plus vomiting. Okay, and this unfortunately lasts several days. Okay, so these are the common differential you should know in an osce station. I don't think they're going to give you anything more severe than this. This gives you a good understanding of what you should know, at least as a student in the osce scenario. Now let's move into the investigations. As in the investigations, you need to be aware of it's just a physical examinations. Mainly, I would just say vital signs, such as BP, pulse, O2, just your vital signs. Nothing really specific, because obviously we've mentioned ear discharge, ear infection, upper respiratory infections. You want to obviously do also like a ear exam, okay, or otoscopy. You also want to do like a neuro examination, just to rule out other causes. Probably maybe mainly focusing on the cranial nerve, nerve examination. That's what I would do anyway. In rare cases, you may want to do bloods if the patient shows signs of infections, but this is generally not required. So I'll just put a question mark just because I'm not sure about it. So at this point you're thinking, okay, I've got most of my history gone, most of my history sorted out. Obviously we've not done the past medical history and stuff like that, but generally in an OSCE station the treatment will always be, let's just say treatment. Okay, let's zoom in a little bit. Treatment will probably be some antiemetic or anti-sickness. The one I think you should be aware is stemetil or chlorperazine. Don't worry too much about the milligram, but it's 5 milligrams. Or the different ones, or you can try out with cetirizine, or another common one that I mentioned is a beta-histine. Don't worry about the milligram, but it will be 8 milligram. Because this is the kind of like antiemetic treatment you will go for in a dizziness station. As usual, like any other OSCE station, don't forget your basics. Obviously, past medical history, family history, mainly focus about Meniere disease, important. Look for any drug and allergy histories, social history, where they live, drinking habits, alcohol and smoking and stuff like that. And don't forget to address the ICE, idea, concern and expectation. I do this every day in my practice. What is the patient concerned about? What is the patient expecting today? And that will probably guide you to how to treat and manage the patient. Okay guys, I think that's it for this video. I hope you guys enjoyed it, and don't forget to like and subscribe to the channel, and I'll see you guys in the next one. Goodbye.